have had quite enough coffee this morning, so I will start keep sipping. We're lucky we get to come in and do this every day. It's good. You're lucky. Think 30 people wanted your seat, and you're the ones that got it. Aren't you going, yeah, that great, that was a prize. All right. Okay, so clinical presentation. So I'm talking more about somebody who has become acutely ill, and now they've sought medical care. So this is likely how they would present. Maybe not with every symptom or every lab value, but in my experience, I did a lot of hospital work when I was younger, and this was very typical for the ER and admitting these folks to the hospital. Okay. Age is usually, you know, Michaela told you, well, I was 18, I was pretty old. So it's very common that most of the time we will see these folks present before age 20. But type 1 can show up any age. Often it will get missed at older ages because we don't expect it. And it doesn't present in exactly the same way. People usually aren't as acutely ill, they're not as symptomatic. The immune system the process seems to slow down. It's most rapid in children and adolescents. Babies can have type 1 before the age of 6 months. We call it neonatal hyperglycemia, and it's a different creature. And then after the age of 6 months, then type 1 can occur. So it's rare to see classic type 1 before the age of 6 months. So children usually are going to be more symptomatic. So let's go over again. Hyperglycemia is the main problem, and that's what's causing a lot of the symptoms. So where does that hyperglycemia come from? What are the sources? Say it again.
The liver is overproducing.
Okay, the liver is releasing a lot of glucose, and where's that coming from?
Glycogen.
The glycogen. Why is it doing that?
It's not responding to insulin.
No, not enough insulin, so absence of insulin. Where's another source of that sugar?
Muscle.
Pardon?
The muscle.
Muscle. Okay, so muscle is doing what? It's breaking down, and it's releasing mostly what? Amino acids, and what happens to them? They go to the liver, and they get converted into new glucose. What do we call that process?
Gluconeogenesis.
Gluconeogenesis. Why does that happen?
Our body thinks we're starving.
Okay, the body needs energy, but what's the other big reason why that's happening? Not enough insulin. Absolute insulin deficiency, or insulin deficiency, severe insulin deficiency. Where's another source? Okay, some in the kidneys. I wouldn't say that's a huge, but it can take place. What else? What's the another big one? Fat. So what's happening in the fat?
Release glycerol.
Breaking down triglycerides into glycerol and fatty acids. Why is that happening? Insulin deficiency. What do we call that process of that fat breakdown? Lipolysis. Okay. There's another source you're missing. Where's our main sugar come from?
Food.
What you eat. Okay, so if they're able to eat, they're getting it. Okay, so those are, you've got to know that. That right there, that's the basis. That's foundation in a nutshell. You got to know that. If you're sitting there going, how did they know that? You've got to go back and look. Because those are the things that are going to be present and accounting for all the symptoms that they have. Okay, so we talked about that under hyperglycemia. And that is a catabolic state. You don't have insulin around, which is the major anabolic hormone, so you now are in a catabolic state. You are tearing down or bringing from reserves of stored energy, fat, muscle, glycogen, in order to produce energy that the body can use. Can the body use it? Not really, because there's no insulin present for it to take it up and use it as energy. It can do it some. The brain can still function, vital organs can still function because they are not insulin dependent on getting sugar into a cell. Muscle, fat, all the ones that are breaking down are the ones that are insulin dependent. So when those free fatty acids are released, where do they go? Liver, and what's the liver do to them? Produces ketone bodies and VLDL, which become triglycerides. So those ketones really cause problems. There are 3 ketones that are major. They're listed there for you. So acetone is a ketone, acetoacetic acid is a ketone, and beta-hydroxybutyrate is a ketone. Yes?
I'm sorry, Dr. Rosati, I don't know what document we're on. I'm trying to
We're on the
figure it
one from yesterday. We're finishing up the end of yesterday, so it is
out. The title of that?
Type 1 diabetes, mellitus pathology.
type 1 diabetes pathophysiology.
Okay, thank you.
You bet. 3 ketones. The ones that we measure are acetone and acetoacetic acid. The largest pool is that beta-hydroxybutyric acid or butyrate. It is a huge pool. It takes a long time to get rid of it. We don't measure it. So there's a lot of unmeasured ions or anions that we don't usually measure. The way they measure ketones, I don't think I put it in there. There's several ways you can do it. If you're a lab person and I'm telling them wrong, you can, this is our old way, I assume they still do this. You can measure ketones in the blood, you can measure them in the urine. The urine takes a while, and if they're dehydrated, they may not be putting out a lot of urine. So you can measure a blood. You can do a blood ketone and wait to get it back. The way ketones are reported, they'll tell you an amount in the blood, milligrams per deciliter, but they'll also give you a ratio like this, 1 to 16, 1 to 32, something like that, or 1 to 64. Okay. What they do is they do a dilution. So they take the blood sample, they dilute it once, and that's a 1 to 2. They dilute it again, that's a 1 to 4. They dilute it again, 1 to 8. 1 to 16, 1 to 32, 1 to 64, and on. If I find ketones here versus the last time I see them is here, which is a more significant value?
1 to 4.
1 to 32, because even in a dilute sample, I can still find ketones, okay? So the higher the number, the more severe the ketosis. So that's one way they can present them, or the labs can come back to you. Okay. This picture on the top of page 6 is really good. It just recaps exactly what we just said. So you might look at it to kind of walk yourself through and quiz yourself about what's happening at each stage. We talked yesterday about renal threshold. So what do you remember about the renal threshold? It's 180 milligrams per deciliter. What does that mean?
When the glucose is above that, it starts putting out into
Okay, so all the sugar is filtered in the capillaries in the Bowman capsule, and enters the filtrate, and that goes into the proximal tubule of the nephron. How do we get it back into the blood?
Reabsorption.
And what does that reabsorption?
A gradient.
SGLT2 transporters and SGLT1. So they take all that sugar and put it back into the bloodstream. Is it normal for people to have sugar in their urine? No. It's an abnormal finding. You'd repeat it. So we would always look at that. Okay, so up until that point, if the kidneys can reabsorb all of the sugar that you are putting into the bloodstream, then symptomatology, they're not going to be very symptomatic. So it's when sugar can start entering into the urine that the symptoms start. So if sugar is in the urine, then we have glucosuria. What happens with sugar and water?
Water follows.
Goes together. So what's the symptom that they're going to complain of? Polyuria. Okay. And then the polyuria will lead to what? Polydipsia, but what also contributes to that polydipsia?
The
Serum
concentration.
osmolality. Okay. So as the serum osmolality goes up, what's monitoring that makes you drink? The hypothalamus. The osmoreceptors in the hypothalamus will make you drink water, free water, to try and dilute down the osmolality. Okay. And then polyphagia occurs at that point, what can occur accompanying that for what reason?
Because you can't use the sugar, so you need more energy.
Can't use the sugar that you're getting from the diet, so you're eating more, which just compounds the problem. You'll see on the very bottom it says that there's, along with water loss, electrolytes such as sodium, potassium, and sodium are also lost. When we get to DKA, we will talk about this. Where's most of our potassium? Intracellular. Big potassium inside, little potassium outside. Okay. How do we get rid of potassium? The kidneys. Okay. So, do cells like to stay electrically neutral, or do they like to be buzzed and be all kinds of gradients across them?
Neutral.
They like to maintain electrical neutrality. So when you've got an acidosis, you've got all these hydrogen ions out here. Where are they going to go?
Into
They're going inside. What's going to exit?
calcium.
So potassium exits, hydrogen ions enter, potassium exits. What happens to the potassium that's now in the vascular system? Kidneys will get rid of it. Early, if you see people really early in DKA, their potassium will be elevated. Don't be fooled. And if the DKA has gone for a long period of time, they'll come in with hypokalemia. That is a bad sign. People in DKA usually will lose about 10 to 20% of their potassium body stores in a very short period of time. Incredible. Okay, so we'll talk about that. So they lose potassium, sodium. This you should write down. I didn't put in there, but it's a little trick you ought to know. So because you've got so much sugar in the bloodstream and it's pulling water in, osmotically will pull water in, you often will get back on their Chem7, their sodium will be low. They'll come back with a sodium of 130. What's the normal sodium? 135 to what?
140.
145. Or they can come back in the 120s. What is that about? Well, it's because of that sugar, and it displaces. You get a kind of a dilutional effect on the sodium. So there is a correction factor. For every 100 milligrams per deciliter of glucose that you are over 100, you add 1.6. Please write this down, and I will I'll add it to your lab medicine. Okay, that's your correction factor. So anytime they've got an elevated sugar, they will usually correct back to normal. So for every 100 milligrams of deciliter of glucose over 100, you add 1.6 milliequivalent per liter to the sodium that is your lab value. So it's 130, so let's walk through it. So let's say their blood sugar is 450 milligrams per deciliter. Let's say their serum sodium comes back at 130. Figure the correction factor on that. What'd you do? 5.6, and so you do what? So the corrected sodium is what? About 135. So, how do you do that? Well, I take the 450, there's calculators and all that kind of junk, but you can do it. 100, subtract 100 from there, now you got 350, so that's 3.5, right? Increments of 100 times 1.6. Is she right? Okay. Everybody see that? One to keep in mind,
Why would sodium be low if you're adding that?
lots of sugar, lots of water comes in, dilutes it out, crowds it out. There's only so much space in that volume that you've drawn. There's also triglycerides. I mean, you've got elevations in things that usually aren't there. High amino acids, you've got hyperaminoaciduria, hypertriglyceride, hyperglycemia. Water comes in with it, somewhat of a delusional effect.
So it's there, but you're just not able to pick it up on the.
It's not abnormal. It isn't in an abnormal, no, it's in the volume that you picked, there's that much sodium, but you correct it because it's not going to physiologically make a change. So what happens usually as sodium drops, what kind of things happen? I think that would be, it's the shifts of water into the brain that usually are the major problem.
Would it take that high of glucose to make that change in sodium? Because the factor just
Yeah.
seems kind of, it would be
Yes.
that high, okay.
Yeah. Would they come in with that? People, okay, so when you have to get above a sugar of about 250 in a type 1 to say they really don't have enough insulin around. So they usually will come in greater than 250. That's why yesterday when I told you about those SGLT2s coming in with a euglycemic DKA, that's why it's so abnormal. In type 1s, their blood sugars are always above 250. But for it to come in a DKA less than 200, that's why they call it atypical. Sakaba?
No.
Question? Okay. All right. Okay, so let's work through a problem with that plasma osmolality. The one you're given there doesn't contain the potassium because it just adds so little. A lot of people just drop it. But you could add the potassium in there. Okay, so figure out the plasma osmolality. If you have a, let's say the sodium is 130 and that blood sugar is 450 and the BUN, let's say the BUN is 40. Calculate that plasma osmolality. It's 2 times the sodium plus glucose over 18. Why do we do that? This converts glucose to an osmolar number. Changes the unit. So what'd you get? 299? So 450 divided by 18, or 40 divided by 2.8. You know, I went back because I couldn't remember if you put the corrected amount in there or not. And I didn't, I forgot to look that up. Put in the 135, see what you get. Is anybody a lab medicine person, I mean a lab tech? Pardon? Did someone say yes? No? Okay. I need to check that to see if you put in the corrected value instead of the serum they measured. So you got 299 with the other one? What is it when you put in the corrected? 309. Okay, what's normal osmolality? Anybody remember? 275 to 295. These are numbers you ought to start filing away. You ought to know your electrolytes by now. When you get in the hospital, that becomes much more of a one that you're looking at. Yes?
Is this something like in a lab, the computer, or whatever we'll do? Because I was a lab tech and we didn't ever have to calculate this. I just didn't know if it was maybe given to you if you ordered certain tests.
You know, I don't know anymore. When I was a student resident, early PharmD, we just did it by hand because I don't remember it ever coming back. But when DKA, I'm almost sure we got that back though. We got that value back. Or if we had hyperosmolar coma, pretty sure that we thought we were dealing with hyperosmolar state that we had that number. Okay, see where all those come from? Those wonderful equations you learned. They're good because they help you remember relationships. They'll help you remember concepts if you'll try committing them to memory. Okay. So we can't forget also, I put in there that ADH is also released. Where's ADH? What's ADH? What's it stand for?
Antidiuretic.
Antidiuretic hormone. And where does it come from?
Kidney.
Pituitary, which part? Posterior, pituitary. And what's its target?
Kidney.
The what? Collecting tubules of the kidneys, right. And what does it make it do?
Reabsorb water.
Okay, so it's always easy to remember, if you drink beer, you inhibit ADH, and if you drink a lot of beer, you pee. So that's the way I remember it. So this also leads to trying to increase that water reabsorption. Okay, so polyphagia and weight loss, we've talked about that. Talked about the weight, amount of weight. Ketones, ketonuria, and ketoacidosis. Okay. So if you are having rapid lipolysis, you are releasing a lot of free fatty acids, a lot. So make yourself walk through those buffering systems. So if you've got bicarbonate, whoops. What's it go to? Carbonic acid. And what's that go to? Carbon dioxide plus water. Okay. So ketones, large acid volume, right there. So it shifts the equation this way. Okay? And within seconds, it doesn't take long, to 15 minutes, you have pretty much consumed that buffering system. So CO2 goes way up. And so what is that? How do we get rid of that? So it increases respiration. So respiratory rate goes up, and there's a special type of breathing pattern that these people will exhibit. It's called Kussmaul. Anybody ever observed it? Okay, tell us, Nathan. What'd you see?
It's like your whole diaphragm is like moving, we're breathing really hard.
It is. It's like this. They're trying, and what's their breath smell like?
Oh, I have no idea.
Oh, okay. It smells like fruit. It reminds me of the apples that used to rot under under our apple trees, that musky, fruity odor. When you smell that and you see that, there's only a few things that do that, and this is, the DKA is one of them. So the body will try to get rid of that. So that's one of the ways we get rid of acetone, is we just blow it off. And that's where that fruity, musky smell comes from. Can the respiratory center correct an acidosis? No, can't do it. So if we were going to look at their acid-base status, what would we see? You got pH. What else could we measure in order to determine acid-base status? CO2, bicarb. Okay. So initially, what's going to happen with pH?
Go down.
It's going to go down. What's going to happen to CO2?
Go up.
It'll go up. And what will bicarb do?
Go down.
Go down. So there's your metabolic acidosis, right? If they come in late and they have tried, their respiratory rate has gone up and they've tried to compensate, then what's it going to look like? What's the pH going to look like?
A little bit higher.
Still down. What will CO2 do?
Decrease.
What will bicarb do?
Increase.
Bicarb won't increase for a while because your kidneys can't respond that quickly.
Oh.
So what is this picture? Is it still a metabolic acidosis? Yes. What is this? And we call this what? Compensated respiratory alkalosis, compensated respiratory alkalosis.
How long will it take the kidneys?
Yeah.
2 to 3 days. You'll never see it because you're going to treat them and resolve the acidosis before the kidneys can be of much help. Okay? Everybody follow that? If you don't, go back and think it through. So, your old friend Henderson Hasselbach will help you remember that. And that's what's on the next, on the top of page 8. So if you look at pH and you look at the major players, so 6.1 is the pKa of the blood. It's not going to change. The 0.03 is the solubility index for CO2. So you can look at it. Bicarb, as bicarb increases, it's a directly proportional. pH is going to go up. CO2 is inversely related. So if CO2 goes up, pH has to go down. If you'll just remember that, remember the equation. I don't have to remember anything else, I just remember the equation. Then I can say, okay, if it goes this way, this pH will do this. Okay. That's pretty much the metabolic disorder, dysfunction. That's, then you can tie to the symptoms, and that's the way the person's going to present. Okay? To me, it's one of the most logical of all the diseases in terms of acute presentation. Remember what happens, what happens when insulin starts with, no, there's not enough insulin. So then what happens to fuel use? What happens to liver, kidney, liver, muscle, and fat? And then those 3 Ps are however you want to remember them, then that's how the person's presenting and why are they presenting. Take it back to the pathophys, and then you can predict what the lab's going to look like. That's the way I do it. Okay, so the very bottom, body habits. Used to, when we would have type 1s come into the hospital, they were always skinny, I mean really skinny. They were usually, had lost significant weight, they were usually they were normal body to begin with. Everybody's fatter these days, so it's not unusual to see people who are heavy come in with DKA. But usually they will give you some type of weight loss in a short period of time. And the thing about the weight loss is that it was unintentional. You heard Michaela say, I was eating more and I was losing weight. One of my professors in college he was a type 1, he had type 1 diabetes. And he told us that when he was diagnosed, he said, he was probably in his early 20s, and he was losing weight, and he was afraid to go to the doctor because he just knew he had cancer. So he went to the doctor, and the doctor said, you don't have cancer, you have diabetes. And he said he jumped off the bed, he hugged the doctor, he said, I didn't have any idea what diabetes was, but I didn't have cancer. So, very dramatic, the weight loss is dramatic. The autoantibodies we've talked about, that they are going to be present, they will help you in your diagnosis. Ketones will be present at diagnosis, so you can look for them in the urine, you can look for them in the blood. In type 1s, their complications will not be present. There just hadn't been long enough time. Now that's different from type 2. In type 2, I don't think that was anything. I saw some of you, the little flitters across your face. Okay, in type 2, complications can be present at the time the person presents. They can have neuropathy, they can have retinopathy, they can have heart disease, they could have kidney dysfunction. Type 1s are not going to have that. Now, if it's due to another disease, that I guess it's possible, but it's not going to be due to diabetes. Lab, here's what you're going to order. You're going to order glucose, your ketones. Chem7 is what we called it. You all called it something else. What, CMP? Okay. The CO2 content on your Chem7 is an indirect measure of your bicarb. So most of the time bicarb is usually a calculated number anyway. So CO2 content would be your indicator of bicarb status. You could get a C-peptide, it will be low, it will not be nil. These folks still make insulin, they just can't make enough to keep everything from tearing down. So if you did a C-peptide, it would probably be less, it would be detectable, but it would be less than normal. So normal is usually 1 to 4. Labs will differ. 1 to 4. So in this situation, it'll be less than 1. Usually they can still measure that. They might come back to 0.7. Bad sign. I mean, it's already telling you it's confirming what you've already suspected. The islet cell antibodies we talked about, the GAD65, their weight. You could refer them, put them in, they'll be sent to diabetes education. This is almost like an automatic referral because we'll talk about the next hour, is that you have to teach them survival skills. So if you do nothing, they can die. They may not die right away, or they could. So you have to teach them, how do you take insulin? How do you monitor your insulin? How do you meal plan, and how do you then match up your insulin with your meal plan? What did they do for you? Were you ever admitted to the hospital? They treat you outpatient?
It was outpatient. He said if I waited any longer, I'd probably end up in the hospital. So he referred me immediately to an endocrinologist in Lincoln, and there was only like one, but she got me in the next day.
Yep.
And then the next day, I was at diabetes education, which helped. My dad and I, it took us like 30 minutes to figure out a glucose monitor, how to like prick my finger and stuff.
Not bad, not bad. So what did they teach you first? Did they teach you how to do insulin before you left the hospital?
Yeah, they teach me at my
out
doctor's
here.
appointment.
Okay.
Yeah, my nurse taught me how to do that. And then he sent me home and like called over the next 3 hours to see if my blood sugar was going down.
Okay. And so what were the first things they taught you in the diabetes education class? Or did you do a one-on-one? Did you have a,
Yeah, it was one-on-one. They did like carb counting, what I can and, or what I should and shouldn't eat. Like how activity levels will affect my blood sugar and stuff like that.
taught you when to take the insulin in relation to your meals?
Yes.
Mhm. Talked to you about maybe sleeping late, getting up early?
Yeah, they said keep a normal schedule, and then they also taught me like emergency stuff and how my parents can use like the glucagon pen.
Taught you the glucagon,
Mhm.
okay, very good. You should remember her story, because she gives you all the bullet points we're gonna talk about, we've either talked about or we're gonna talk about in the next hour in terms of management. Okay, very good. Anything else you want to tell them about what we talked about today?
Not that I can think
Did they test ketones on you?
Yeah, yeah,
Okay.
they were high. I had that fruity breath. And I could taste it too, but I didn't think anything of it.
Good. Yep, you were lucky you went in.
Yeah, he said within a week I would have been in the hospital. But I also called that summer and explained my story. I said I'm a new lifeguard. He thought I was dehydrated, so he told me to start drinking Gatorades. So I was drinking so many Gatorades, which was just throwing it out.
It probably it probably helped you get diagnosed.
Yeah.
Because they just gave you lots of sugar and
Yeah.
stuff.
I was having a lot of sugar.
But they also replace electrolytes, so
Yeah,
there's
and
some
that's what
soda.
we wanted, yeah.
Yeah. Okay. Questions about what we've talked about or for Michaela? What did you think when they gave you the diagnosis?
Shock. But I knew something was up. I was kind of nervous, like how you said, I was kind of nervous, like, could this be cancer or something? I wasn't relieved that it was diabetes, because, I mean, I've heard people say, like, sometimes cancer, can be curable, so that's kind of better than a chronic illness. Yeah, it was shock, but, like, my dad said, lucky it was you and not your brothers, because they would have not dealt with it at all. Like, their blood sugars would be out of control, so.
Is that comforting? He probably was comforting himself.
Yeah, he was like, well, thank God it's you and not.
Okay, let's take a short break. Thank you for